So welcome everyone. This is a very nice day for me because I'm happy to introduce two of my, big friends when I was in Boston. Dr. David Zurakowski, who is I would say, one of the leading biostatisticians, for sure at Boston Children's Hospital, but in Boston and Harvard University in general. He taught me a lot about biostatistics, and also helped me a lot in understanding what was a very difficult field for me, as probably all cardiac surgeons. And the other friend that I'm introducing today is Steve Staffer, probably one of the nicest guy I met in Boston. Steve is a very enthusiastic biostatistician, a graduate from Harvard, and he's also currently working at Boston Children's Hospital. So thank you very much to both of you for being here today with us. So I'm going to stop sharing my screen, and you can activate yours.
Sure. Okay, do you see the screen here?
Yeah, all good.
So first of all, buongiorno everyone, and it's great to see everyone. Grazie to Elvisi for having us on, me and Steve. And I guess just a little mutual admiration, when Elvisi was in Boston, he also really taught me and Steve quite a bit about cardiac surgery because we collaborated on several projects, which was a very positive experience, I feel, for everybody. So we really learned a lot from each other. And I think in the spirit of collaboration, that's really what it should really be about. It's collaborative, and it's a lot of reciprocation and that learning to try to create some good papers and some good publications. The topic this morning is more or less a tutorial, and it's powering your time to event outcome studies. And we felt that this topic would be very helpful in your work. That's the reason that we chose this topic. You're all extraordinary people trying to save children's lives. So it's very important that your clinical research have the most credibility possible. And from what we've seen, certainly Steve and I are very active in several cardiovascular journals as reviewers and editors. And very often, especially in time to event outcome studies in cardiovascular surgery, they're limited due to low power. They just don't really have the sufficient numbers of patients for drawing meaningful conclusions and giving credibility to the results. So consequently, we decided to focus this tutorial and this lecture today in Italy on laying out the steps to do power calculations for time to event outcomes to ensure appropriate numbers of patients for detecting clinically significant differences, which we usually refer to as clinically significant effects. Those could be treatment effects, intervention effects, identification of important risk factors for outcomes, where you're studying outcomes not only as a comparison between treatment groups or patient groups in terms of whether or not they occur, but also when they occur, hence time to event outcomes. And we believe as a priority, more or less as a vision, that in designing your studies, to try to think about this and to try to discuss it as early as possible to ensure that you have sufficient sample sizes, since this will give more credibility to your interpretations and your conclusions. So I guess the message there is to have this dialogue with your biostatisticians early on so that you could have an optimal study design. This is part of the study design process, and that you could ensure that you have sufficient power for essentially having meaningful data. Meaningful data means in the interpretations and in reporting and releasing that information to the cardiac and cardiovascular community. So again, I'd like to thank Alvisi for inviting us. I'd like to also introduce my colleague, Steven Staffa, and we're going to give a tutorial now. Steve's going to lead the charge, and then we'll save some rooms for Q&A at the end of the talk. Thanks very much.
Yeah, thanks, Dr. Z. So thanks for that introduction and for that background and motivation. You kind of touched on this first slide that explains that time to event analysis is very common across a wide range of specialties, but in particular in cardiovascular and thoracic surgery. In this field, common endpoints might be time to mortality, time to reoperation, recath, hospital or ICU readmission, reintervention, and graft failure. The key being that it's time to this outcome that you're studying, not just a binary event, but you're following patients over time and determining at what time did they experience the event of interest. And like Dr. Z was saying, statistical power is an essential element in study design to ensure that sample sizes are sufficient for detecting treatment effects and establish credibility and confidence in your results of your study. So we'll be walking through a 5-step strategy for determining sample size with the focus on time to event studies. And we'll be walking through these 5 steps using 5 examples or scenarios in cardiovascular surgery. So to first walk through the 5-step strategy, it's a general template. In step 1, you should identify the primary outcome of interest. Like I mentioned, it might be survival, reoperation, readmission. Once that's determined, in step 2, it's a matter of defining the treatment effect, which could be an intervention effect, comparing groups or comparing patient cohorts or comparing different surgical strategies. The treatment effect itself is, in time to event studies, will be usually a hazard ratio, which people are familiar with. Usually comes from Cox regression, time to event regression modeling. So you could consider a hazard ratio as the treatment effect, or you could consider a difference in median survival if you're comparing Kaplan-Meier curves for the time to event outcome. And you want to define the power and alpha. Alpha is the same thing as the p-value, significance level, so usually 0.05. Power is has to be set at 80%. That's what the different agencies like the NIH will require, 80% power. Sometimes you might want 90% power for some more statistical power. So once you do the first few steps, it's time to determine the appropriate statistical test that will be used for the power and sample size calculations, as well as the analysis once the study is completed. So like I was already alluding to, this might be Cox regression if you're talking about a hazard ratio, or competing risks modeling if you have a competing event that might prevent the patient from experiencing the event of interest. This might be like early mortality if you're studying time to readmission or something. The log rank test would be used for comparing Kaplan-Meier curves. So all of these discussions will be had between the statistician and the investigators and surgeons. It's a dialogue. It's not just like a linear, like step-by-step path that is like set in stone. It's kind of a back and forth dialogue regarding feasibility, number of patients available, etc. So once you have all that information ready, you can perform the calculations and discuss the sample sizes. In this talk, I'll be showing some output and user interface for PASS, which is a sample size software. But other software can perform the calculations, such as R, which is free and open source, as well as GPower, which is free. nQuery and PASS require subscriptions, but lots of options for where to perform the calculations. And then lastly, it's a matter of writing in step 5 to write the formal power and sample size statement, which will be included in your manuscript or in your grant application. We have an article in press in JTCVS that has more details, but this talk is based on our article, which will be published shortly. Here we have a glossary of statistical terms. I don't want to walk through every single one, but just highlight a few. The first being alpha, which is also the p-value. This is the probability of type 1 error or rejecting the null hypothesis when it is true. In other words, false positive results. Typically, we will set p as less than 0.05. Power is the probability of rejecting the null hypothesis when it is false, often set at 80% or 90%. In other words, the probability of identifying an actual treatment effect. So I'll be using those terms, and that's what I'm referring to. The hazard ratio is a key statistic from Cox regression. We've kind of defined some benchmarks for effect sizes here, small being hazard ratio of 1.5 to 2.5, moderate is 2.6 to 3.5, and large is 3.6 to 5. So we'll be talking about hazard ratios, so I wanted to define it here. And lastly, competing risk is another event other than the outcome of interest. So a competing risk might be mortality that may precede the outcome of interest and therefore prevent or preclude the patient from experiencing the outcome of interest. So now I'm going to walk through our 5 examples, each one going through our steps for power and sample size determination. In example 1, let's consider a study that is being designed to compare survival in HLHS patients undergoing lateral tunnel or extracardiac conduit for Fontan operation. So here, based on this background, we'll walk through the 5 steps. So in step 1, the primary outcome of interest is time to mortality. Sorry about that. In step 2, thinking about the effect size and the power and the p-value, it's determined in conversation with the surgeons that a hazard ratio of 2 or 3 would be a clinically meaningful effect with regards to time to mortality, comparing these 2 groups, the lateral tunnel and the conduit groups. We're going to define the power as 80% and p-value as p less than 0.05. Those are traditional and standard practices. Based on that, in step 3, we determine that Cox regression will be used, and we also need to assume a 20% probability of mortality in each group, just based on clinical knowledge or discussion with the surgeon. We can come up with a estimate of that probability that will go into the calculation as one of the parameters. So that's why we need to do that there. But that could be based on historical data or previous studies. So then in step 4, it's time to do the calculations. Here we're using PASS software. And on the next slides, I'll show the PASS user interface and the inputs here, and then I'll show the output. So here's the input for the Cox regression for 2 groups. As we discussed, the power is set at 80%, alpha is 0.05. We're asking for equally sized groups, so N1 equals N2, the same sample size in the 2 arms. And here's that proportion of events observed, in other words, the probability of a mortality in each of the 2 groups. PASS calls a control and treatment, but we know that we're talking about the 2 surgical groups in this scenario. And lastly, the effects.
Steve, I want to just mention one thing.
Sure.
Since this is a very common scenario that we encounter in a lot of cardiovascular studies for time to event. So here again, we're looking at hypoplast patients undergoing Fontan. We're comparing lateral tunnel to an extracardiac conduit. We're looking at mortality. What's going to drive the sample size requirements is really that choice of the effect size or the hazard ratio. And basically what that means is, how often do we see deaths occurring in each of those 2 groups along the follow-up? And if we want to have the power to detect a smaller effect size, which means a smaller hazard ratio, that's naturally going to require larger patient numbers. But the question boils down to, in this dialogue between the surgeon and the statisticians, how small of a difference is clinically meaningful, and how many patients could we afford to study, either retrospectively or prospectively, to be able to find clinically important differences. So it really truly is that hazard ratio, that effect size, and the size of the hazard ratio that's the key driver for the sample size requirements. Sorry, Steve.
No, that's exactly a great point. Yeah, so the last thing I want to point out here is that this will calculate the sample sizes associated with an effect size of a hazard ratio of 2 as well as 3. So that's why I wrote 2 and 3 here. This is a menu-driven software, so it's very user-friendly, and there's no coding that's involved. So that's an appeal of this software. Like many other sample size softwares are menu-driven. This is the output that it gives you. For each of those scenarios, the hazard ratio of 2 in the first row and the hazard ratio of 3 in the second row, and all of the other parameters that we input, like alpha, beta. Beta is 1 minus power. And here we can see the sample sizes per group, which is, if you want to detect a hazard ratio of 2, you'll need 164 patients per group. Whereas if you want to be able to have the power, 80% power to detect a hazard ratio of 3, then you will need fewer patients, like David mentioned, which would be around 66 patients per group. So in step 5, writing down this formal power statement for your manuscript or for your study design document, you can say that assuming 20% mortality probability, 80% power, and a 2-tailed 5% alpha or p-value, a sample size of 164 patients per group is required to detect a hazard ratio of 2, and 66 patients per group is required to detect a hazard ratio of 3. So based on...
The only thing we could add to that, Steve, is again to finish that sort of statement, using, in this case, Cox regression for time to event outcomes.
Yes, Good point. Baseline Cox regression for this time to event outcome, time to mortality. Yes. So that, like that example was based on the hazard ratio. So this graph here shows different sample sizes per group that are associated with 80% or 90% power for varying sizes of the effect or the hazard ratio. So for small effects, hazard ratio is 1.5 to 2.5. You need more patients per group than if you want to detect a moderate or large effect that requires fewer patients per group. And you can see that the trade-off is, it's not linear, it's like a curve. So it's kind of useful to look at this sort of graph in the context of feasibility, how many patients you have at the hospital, or how many surgical cases are performed, each year that you can enroll in your study. This next graph is similar, but it shows how if you change the p-value or the alpha, that will also change your sample size requirements. A smaller alpha is associated with larger sample size requirements. A smaller alpha might be also referred to as more conservative, or might be used if you're testing multiple outcomes. Excuse me.
I think in most situations, this is a really good example because, like I said, it's a very common scenario. But most of the time, I hate to kind of phrase it as being like in the middle of the road, but very often what is clinically significant is being able to have sufficient power and enough patients to be able to detect moderate effect sizes. So hazard ratios typically between 2.5 and 3.5. And you could see, even maybe if you go back to that previous graph, Steve, that the sample size requirements to detect a moderate hazard ratio between lateral tunnel versus the extra cardiac conduit groups would be somewhere between 100 per group and as small as even 50 per group for 80% power. And you could see, as Steve mentioned, the relationship there is if you want to be sensitive in detecting smaller effects, smaller hazard ratios, then there's a cost trade-off. You're going to need more patients to get the job done. Sorry,
Yeah,
Steve,
absolutely.
Your next example.
No problem. I had to drink some water. It's tickling my throat. But yeah. So let's move on to the example 2. Here is another common scenario where we'll discuss log rank tests. So here, let's consider a study is being designed to compare Kaplan-Meier curves for reoperation-free survival for, let's say, mitral valve disease patients with mitral regurgitation versus mitral stenosis undergoing mitral valve repair. This is just a all these examples are supposed to be cardiac surgery, cardiothoracic surgery, but they are hypothetical. So in step 1, let's define the primary outcome of interest is this composite time to event outcome, which is reoperation free survival. In step 2, to determine the effect size, based on historical data from previous studies, the investigators assume a median reoperation free survival time of 12 months for MR and 6 months for MS. So that means, whether this is a hypothetical example, but this is saying that in 12 months, half the patients experience reoperation or mortality in the regurgitation group, but in the stenosis group, it's the median time to event is 6 months, so it's kind of worse in that group. And we want to be able to have large enough sample sizes in these two groups to try to demonstrate this difference in reoperation-free survival. So since we're talking about a Kaplan-Meier curve, the log rank test will be used in step 3. In step 4, in PASS, the investigator needs to put in some additional parameters or information. So the investigator assumes a 1-month accrual period, which is when patients are enrolled, and then 24 months of follow-up for all patients in the study, and then as well as a 5% attrition per month, which is also known as censoring. I have the PASS output at the end of the slides in case we want to look at that later on, but for now I just want to continue through these examples. So in step 5, after running the calculations, we can say that based on the log rank test, a sample size of 57 patients per group, or a total of 114, would be required to detect this difference in reoperation-free survival between the two groups.
So Steve,
again, based on all those numbers.
A very excellent example, because it's just showing that people are familiar, and surgeons are quite familiar with Kaplan-Meier curves. Meyer, in fact, was my PhD advisor at the University of Chicago. That's over 32 years ago. But long story short, the test statistic of interest here, the log rank test, is really testing the hypothesis that reoperation-free survival in these patients with congenital mitral valve disease is equal between those with stenosis, mitral valve stenosis versus mitral regurgitation. And the goal here is to evaluate essentially during the follow-up period when these reoperations or deaths occur. Are they occurring earlier and more often for patients with mitral valve disease that have stenosis or not? And essentially, what your power analysis allowed us to determine here in terms of sample size requirements is essentially almost 60 patients per group would be required to be able to detect essentially a difference in those two groups in terms of reoperation-free survival using a log rank statistic for comparing the Kaplan-Meier curves. Excellent. Yes. And again, a very popular, very common scenario.
Yeah, that's why we wanted to start with the Cox regression and then this log rank Kaplan-Meier scenario. Our next scenario is for a 1-sample log rank test where you just have one sample, one group of patients. So a study is being designed to determine if the median survival is improved with a new treatment versus a historical control group, and what effect size can be detected based on a study sample of 30 new treated patients. So you just have this one group of 30 patients with survival data. The primary outcome of interest is survival. In step 2, it is known that from the historical controls that the median survival in that historical group was 3 years, and the investigator wishes to determine the beneficial effect or improved survival of the new treatment in these 30 new treated patients. So in step 3, it's determined that a 1-sample log rank test can be used as an appropriate statistical approach for the sample size and power calculations. based on all these parameters in steps 1 through 3, in step 4, the calculations are performed and passed. And in step 5, the formal power statement would be that based on a one-sample log-rank test, 30 patients provides 80% power for detecting a median survival of approximately 6 years in the treatment group, which is, in other words, 3-year longer survival than historical control, assuming a 5% alpha or p-value of 0.05. So this is saying that if we had more patients, if we had, instead of 30 new patients, if we had like 50 or 100 new patients, then we would actually be able to even detect a smaller effect size or a smaller improvement in survival than this scenario where we're saying 30 patients provides power for a 3-year longer survival.
So again, an interesting scenario, because the investigators want to know in planning this kind of a study that compared to historical data, is this novel therapy or treatment extending patients' lives, and by how much? And that how much, again, is the key. So in this case, does it extend or lengthen the median survival time, the new treatment, compared to historical data? And the power calculations basically said, okay, you got 30 patients available. How large of a difference, if in fact there is a benefit with longer survival time, can you achieve? And with 80% power, you could detect essentially at least an additional 3 years in terms of improved survival based on this new therapy.
Yes.
Okay.
Example 4 might be the most statistically complex one because it's competing risk analysis. Here a study is being designed to compare time to readmission between African American and white patients undergoing CABG, accounting for early mortality as a competing event. So here in step 1, the primary endpoint of interest is time to readmission, and early mortality is regarded as a competing event since it may precede readmission and prevent patients from experiencing readmission. In step 2, patient accrual time will be 6 months, and the study follow-up period will be 1 year after accrual closes. And investigators have actually collected data on 200 white patients and 100 African American patients and wish to justify these sample sizes for detecting a clinically meaningful difference regarding time to readmission. So in this example, rather than calculating the sample sizes, we are actually going to calculate the effect size given this, cohort that is of data that it already exists and we already have 200 patients and 100 patients. So since this is a competing risk scenario, we'll use a log-rank test accounting for competing risks, which is an option provided in PASS or any other sample size software. And based on all of this information in steps 1 to 3, we calculate that in step 5, assuming a 5% incidence of early mortality and a 10% incidence of readmission in the 4 white patients, these sample sizes above provide 80% power using the log-rank test to detect a hazard ratio of 2.3 between the groups, accounting for early mortality as a competing risk. So in other words, powering the study with enough patients in each group will provide clinically meaningful evidence as to whether the time to readmission following CABG surgery is earlier for African American patients compared to white patients. And this hazard ratio of 2.3, kind of like what we've already discussed, is is a small to moderate effect size, which might be clinically meaningful for comparing these two groups. Our last example, I want to save a little bit of time for any questions, so I'm going to continue. Last example is accounting for clustering of data, clustered data. So a prospective study being designed for adult patients undergoing aortic valve replacement with prolonged cross-clamp time greater than 90 minutes to compare Del-Nido cardioplegic solution, DC, versus conventional cold blood cardioplegia, BC, for myocardial protection. The study will include 10 surgeons at a single center where each surgeon does an average of 30 cases, 15 with DC and 15 with BC. So we're going to be accounting for this surgeon clustering of patients in the sample size calculation. In step one, the primary outcome is time to discharge from the cardiac ICU. So it's a time to event study. The investigator is interested in assessing whether DC is associated with earlier discharge than BC. In step two, the investigator determined, based on the number of cases per surgeon, that there are 150 patients per strategy clustered within the 10 surgeons. So there are a total of 300 cases. Because of this clustering, in step three, a weighted log rank test is used to account for patients from the same surgeon. And going into PASS, this can be done as one of the options, a weighted log rank test. And in step five, assuming that BC has a 70% rate of early CICU discharge, and also assuming a within surgeon correlation of 0.2, this could be called intra-surgeon or, intra-cluster correlation. In other words, the patients who have the same surgeon are correlated at least a little bit with regards to their outcome. So based on that, a sample size of 150 patients per group, total of 300 patients, will provide 80% power to detect a hazard ratio of 2.7, comparing DC solution versus BC, i.e. a faster rate of discharge with Del-Nido solution. So again, this calculation was intended to determine the effect size, the hazard ratio of 2.7, to kind of justify or defend that this sample size of 300 cases was robust or was large enough to make a clinically meaningful comparison of these two groups. So again, that was the last example. So just to conclude, investigators should design their time to event studies to ensure sufficient statistical power, typically 80% is required, for detecting clinically meaningful differences and to provide clinical assurance of their results and conclusions. Power calculations are an important element of study design and methodology and are required in grant applications as well as interactions with NIH and FDA or other agencies. Studies designed to evaluate time to event outcomes should include power and sample size calculations to ensure that the results are based on sufficient numbers of patients and provide credibility and validity of the research. And last but not least, feel free to reach out to us with any questions or advice on power calculations when designing your studies, with time to event outcomes in particular, since that is, some people are less familiar with that.
So, Steve, I wanted to just add, that last point, and I'm glad that you mentioned that, because, like you said earlier, this whole process of designing a study is really where discussions regarding sample size and power considerations belong. And that dialogue between the surgeons and the statisticians, again, need to take place. Otherwise, the statisticians essentially and very often come up with the right answer to the wrong question. So there needs to be a dialogue, but that dialogue, sometimes the surgeons, even when they're familiar with time to event data, because we're surrounded by studies in JTCVS, in the annals, in circulation and JACC. We constantly see Kaplan-Meier curves everywhere, and we constantly see multivariable analyses everywhere. But very often, and this is very critical, the critical point in determining appropriate power and sample size requirements is when you're starting to design the study. And very often, those discussions can get rather involved. So I guess what we're saying here is, if you find that you're in trouble or you need some advice with actually doing a power calculation, find the software that you have available. If it's the free software like G-Power that comes out of Dusseldorf, Germany, it's free. It's very good. PASS software, it's not that expensive, but of course Harvard has a license, so we have that available to us. Or whether it's Enquiry Advisor out of Boston, it also comes out of Ireland, also excellent for sample size determination. But have these discussions early. Have them with your statisticians, and if you run into some trouble or if you have some questions, as Steve said, feel free to reach out to us. We'd be happy to give some advice.
Thank you, Dr. Dre. And thank you, Stephen. I think this was a great lecture, especially because before making questions, I would just make a point, like my personal point or my personal experience. I think the topic of this lecture is actually key for cardiac surgery and cardiac surgeons in general, for different reasons. The first reason is that usually cardiac surgeons, and myself included, like, we underestimate, the importance of statistics when we are in training and when we grow up as cardiac surgeons. And so when we end up like starting, writing papers, submitting papers, and this is what I experience now as a, reviewer or editor, you see that there are basic information that are missed by the author submitting the paper. And this is bad. It's bad for the author because you're losing time. It's bad for the journal because maybe you end up not accepting a paper because of a statistical problem. So my first statement is we need to learn statistics as cardiac surgeons, and I'm sure you have the experience of how many cardiac surgeons or cardiologists actually know statistics and can deal with these things. The second thing is that this topic is particularly important in congenital heart disease, because as you all know, you are Boston Children's Hospital, and you usually don't have issues with the numerosity of the sample sizes. But because we are talking about very specific disease and sometimes very rare disease, sample size is a big thing in our field, in our world, because many times we face the problem of having a small sample size with underpowered studies and with biased results. So that's why usually we end up doing multi-center studies or meta-analysis just because of this reason. And on this aspect, I need to stress the effort that was made by the different associations like the AATS, the STS in North America, but also like the ECHSA and the ECHSA-SICCH for cardiac surgery here in Europe to make like European or North American database. And then like when you have big data sets, then you can have conclusions. Otherwise, it's very hard in our world. But I think this is a very important topic because I don't know how many of in the audience are reviewers or editors in our journals. I know that for sure Professor Sterling and Dr. Di Salvo are, and we face daily the problem of a sample size. There are several papers that come out with nice ideas and everything, but then you have 10 patients per group. What can you say of with 10 patients per group? So that's great, like all you explained today, because people can understand that before submitting a paper, before reaching conclusions, you need to have the fundamentals behind you. So there are several.
I see. I would like to add that the reason that we wanted to lay out this sort of 5-step strategy is that the discussion when you're designing a study, you've got a good idea. It'd be a shame not to pursue that idea, but it may be that patients are scarce. It may be something rare. It may be hard to get the patients that or the numbers of patients that you would like to have in designing this study, but still going through these 5 steps and being able to write a formal power analysis statement is still going to give more credibility and more validity to the research, and ultimately is going to have your study that you put a lot of energy and effort into, it's going to have more impact. By the way, Dr. Patterson told me yesterday that you were just promoted to associate editor at JTCVS.
That's
so I wanted to congratulate you on that.
That's just thanks to you.
It's very well deserved. So I'd like to open it up for some questions.
So there are several statistical students from the statistical unit here in Padua, directed by Professor Gregori. So maybe they have technical questions for you. Otherwise, I'm going to look for the audience here. We have a big room here of residents and
wow,
video residents. Any questions? Maybe from the audience.
The other notion here that I think Steve did a very good job in trying to explain is there is a dialogue that goes back and forth because there's some practical, logistical, and economic constraints in designing clinical research studies, particularly those that are timed to event clinical outcomes. So going through these sort of practical 5 steps as a strategy, sort of like an exercise, will shed some light sort of realistically on how many patients ideally you would like to include in your study. And then there's the discussion of, well, to do what? Well, to be able to be sensitive to a certain effect size. So it may well be that if you don't have the luxury of including as many patients in the study groups or the treatment groups that you would ideally like to have, your study design and your analysis of sample size analysis, sample size determination or justification will at least allow you to understand how large of a difference, clinically speaking, you can detect with sufficient statistical power based on the sample sizes that you do have available or based on the sample sizes that are realistic.
Yeah, absolutely true. So, since if there are no questions, I think we can free you. Again.
So again, I think we're trying to inspire a distinguished group of Italian surgeons this afternoon there. I know it's in the afternoon on Friday. It's a little difficult maybe to get excited about statistics at this hour on a Friday. But I think what, you know, the main goal here was to communicate that it's an important topic in designing your studies. And it's a topic that you should discuss early on in designing your studies. Yeah. And if there's any help that we could provide to answer any questions or give some advice, we'd be very pleased to do that.
Thank you so much. Yeah, as you know, like, you know, Friday afternoon in Italy, it's already holiday. So maybe we're sleeping. But thank you so much again. It was a pleasure. And I'll give you your contacts to anyone that wants to reach out to you. And thank you so much. Have a great weekend.
Nice to see everybody. Thanks, Elise. Have a nice weekend.
Thanks.
Thank you, Steve. Bye, David. Bye-bye. Thanks.